Welcome everyone to the 9th webinar in the Governing for Reform in Aged Care webinar series. This webinar is focusing on improving clinical governance culture. My name is Nikki Doyle, the lead partner at KPMG for the ageing sector. It is my pleasure to be your host today. Before we commence, I would like to acknowledge the traditional owners of the lands on which we are all meeting upon today. I am on the land of the Gadigal people of the Eora Nation. We pay our respects to elders, past, present and emerging. We acknowledge the deep feelings of attachment and relationship of Aboriginal and Torres Strait Islander peoples to country. We also pay respects to the cultural authority of Aboriginal and Torres Strait Islander people attending from other areas of Australia. New clinical and corporate governance obligations were introduced in December 2022 under the aged care reforms. These highlight the importance of building a good clinical governance culture within your organisation and the importance of your role as an executive or governing body member in leading and managing clinical governance effectively. The Aged Care Act and Aged Care Quality Standards set out clinical governance obligations which specify outcomes for consumers related to their health and well-being, including through the provision of safe, high-quality clinical care. It is important that everyone in your organisations are not only aware of how they can demonstrate compliance with clinical governance obligations, including understanding what is expected of them in practice, but also, and perhaps most importantly, are empowered to work collectively to drive a culture of continuous improvement with the aim to deliver outstanding quality care. During today's webinar, we are joined by Dr. Julie Phillips, Dr. Melanie Roth, and Professor Marie Bismarck, all of whom I am very excited to be joined by today. And I will introduce them more formally shortly. The overall aim of the discussion today is to explore the importance of building a good clinical governance culture within your organisation and your role as an executive or governing body member in leading and managing clinical governance effectively. Before we get started though, I am conscious that while many of you joining us today have been participating in the program for some time, others may be quite new to the program and wondering what Governing for Reform in Aged Care is all about. If you're here for the first time, welcome to the program. As a registered program participant, if you head to the Governing for Reform in Aged Care website, you'll have access to a range of resources that we shared prior to this event, including the Clinical Governance Online Learning Module, the Continuous Improvement Online Learning Module, the Continuous Improvement Succession Planning Toolkit, all of which will help support your learning from today. You'll also find recordings from all of our previous webinars and information about opportunities to get involved in other parts of the program. We have also just uploaded our governing body packs, which support you to work through aspects of Governing for Reform collectively as a governing body. Before we dive into our panel conversation today, can I draw your attention to the layout of the screen? You'll notice that you can manipulate the screen in any way you like. So if you'd like to see the presenters in full screen, you can expand the various windows to suit your preference. We're also really keen to make this an engaging discussion. So if you'd like to submit a question for the panel, please do so in the question and answers box on your screen. And I note that even before we've started, we've already have a couple of questions already, which is fantastic. We will aim today to leave about 10 to 15 minutes at the end of the event to select a few questions for the panel members as time allows. So as mentioned today, I have the absolute pleasure of hosting the web panel discussion on such an important issue, which is clinical governance culture in aged care. So please join me in welcoming our wonderful panellists for today. So first of all, it is my great pleasure to introduce Dr. Julie Phillips. Dr. Phillips is an experienced senior executive in the health industry for over 10 years. Dr. Phillips provides strategic advice to executives and governing bodies in the field of clinical quality, safety and risk management in complex health ecosystems. Julie was a medical director at Medibank Health Solutions and now owns a consulting business assisting diverse organisations across the corporate, not-for-profit and military health sectors to develop new models of care underpinned by governance, clinical quality and safety right-sized for their clinical risk profile and strategic directions. Welcome, Julie. Next I have joining me is Dr. Melanie Roth, who's the Chief Clinical Advisor for the Aged Care Quality and Safety Commission. Dr. Roth is a senior staff specialist in geriatric medicine at Royal Prince Alfred Hospital. She has been extensively engaged in clinical teaching, especially in geriatric medicine, and is a clinical senior lecturer in the Faculty of Medicine and Health at the University of Sydney. She has been a consultant to the New South Wales Medical Council and a senior member of the Guardianship Division of the New South Wales Civil and Administrative Tribunal. Dr. Roth is the Chief Clinical Advisor for the Aged Care Quality and Safety Commission. Welcome, Melanie. And last but certainly not least, I would like to welcome Professor Marie Bismarck, who is a board member at the Royal Women's Hospital and also a non-executive director at Somerset Group Holdings, who operate within New Zealand. Professor Bismarck is a medical practitioner, a health law academic, company director, and a mother of three. She heads the Law and Public Health Unit at the University of Melbourne, where her research explores the intersection between health practitioner wellbeing and patient safety. In addition to her academic role, Professor Bismarck works as a psychiatry registrar at the Capti Mental Health Clinic. She serves as a board member, as I mentioned, at the Royal Women's Hospital, GMHBA Health Insurance and Somerset Retirement Villages. Professor Bismarck is the chair of Somerset's Clinical Governance Committee and has been a director of Somerset since 2013. A very big welcome to you, Marie. So to start us off, I'm interested in each of your perspectives on the importance of building a good clinical governance culture within your organisation. So Melanie, can I get you to start us off with your observations?
Yes, clinical governance culture is just a part of the overall organisational culture. It's not an isolated, standalone thing. That clinical care and care are absolutely intertwined, and you can't separate them really. So as an organisation that is focused on clinical governance, I think you would need to be very clear on the purpose of what you are there to do. Which would include clinical care and all of the things that impact on it and all of the things that flow on from it. And that is extremely broad. So it would be very important for the people responsible for fostering the culture, which is always from the top. So that would be the board and senior management, that they are clear on the purpose and the expectations of you as an organisation. And the purpose would always be good outcomes, good processes, that it's a good place to work in and a good place to reside in, and that you have a good reputation, and that you are trusted by the community and the regulator. And understanding, I think, that everyone has a role in clinical governance, because it goes to risk detection and solutions, suggestions, nipping things in the bud, and even all of non-clinical people can see when things go wrong and need to be able to know that you want to know these things, because if you don't know these things, you don't really know what's going on. And the people concerned need to know that you're supporting their efforts to foster good governance and good culture, and that everything they bring upwards is taken seriously and escalated appropriately, so that people are taken seriously. So I think it's empowering, being risk and solution focused, and genuinely knowing what's going on. So just assuming that something's going on because it's in a statement is not the same as getting on the ground knowledge and really speaking to a number of people and seeing where you think the problems lie and where you think the good things lie.
Fantastic. Thanks, Melanie. Julie, I'm keen to get your insights and to build on what Melanie's just said.
Thanks, Nikki. Look, I've worked across a range of sectors, not only aged care, And to me, culture and a culture of quality and safety is really the begin and the end of it all, along with leadership. And for me, the thing that I've seen across all industries is that, to be honest, clinical governance is a bit of an image issue. It's a pretty boring topic to a lot of staff, unless you're people like us that are really into it. So one of the biggest issues, I think, is making it engaging to people throughout your organisation and translating what clinical governance actually means for them. And doing that via stories is really important. And through that, then you'll start to understand, you'll start to translate what clinical governance is, what the expectations are for your staff and people throughout your organisation. And the other thing about culture too is that you won't have one culture. You will have probably a range of microcultures throughout your organisation. Some of them might be the ones you want. Some might not be aligned with how the behaviours that you want. So I think just as important about having a culture is understanding those microcultures. And that might be okay, right? As long as they're all kind of pulling in the same direction in alignment with your strategy, then that's okay. But understanding those microcultures, and that also aligns with the principles of safety 1 and safety 2, which is spending time on things that go wrong, such an important part of quality and safety, but also understanding and spending as much time on those things that are going right. Where are those microcultures that are delivering great care? And really understanding what is going on in those teams, those facilities, those areas of your business, I think is the real, the magic in clinical governance.
Fantastic. And Marie, interested in your perspectives.
Thank you. So I've been with Somerset for a long time now, and we've always said that the key question in clinical governance for us is the care that we provide good enough for our own mum or dad? And I've seen that through a very personal lens recently, with my dad being admitted to one of the Somerset facilities, and it's really taken clinical governance from the boardroom to having a lot of personal meaning for me. That a good culture of clinical governance means that I know my dad will get the right medicines at the right time, that the nurses will be caring and compassionate, that he won't be left feeling alone or frightened, that if there's feedback provided to the facility, that they'll learn from that. If something goes wrong, that the family would be informed about that. And most of all, that people feel safe and happy receiving that care, which is only possible when the staff members feel safe and supported in the work that they do.
Fantastic. Can I just have a follow-up question from you, Marie? What do you think then are some of the strengths that governing body members need to demonstrate to be able to deliver what you've just described?
There are a few strengths that I think governing body members need. Having the right values is part of it. I think that members of the executive are always watching and taking cues from board members. And if we are caring and compassionate and place our residents first, then that gets communicated through the whole organisation. So I think values are incredibly important. I think courage is an important value, that sometimes you have to take brave decisions. So, for example, when we really wanted to improve the quality of our care, we decided to open up all of our internal quality data to other aged care providers so that we could all share and learn from each other. And that took courage as a board. And then the third value, I think, is curiosity, just always wanting to know, wanting to understand, being really curious about the experiences of our staff and our residents. And part of that curiosity involves getting out into facilities yourself and actually sitting down and sharing a lunch with residents and staff.
Fantastic. Julie, I'm interested in your perspectives in terms of your roles, particularly with Uniting New South Wales, but also more broadly about the same thing. What do you think are the strengths that governing body members need to demonstrate to address these challenges around clinical governance that you described?
I think Marie has mentioned a lot of the things I would have said, but just to build on that, I think that questioning mindset is so important. Wanting to understand why is it like this? Why is this metric that way? What is that story telling us? So that continually questioning mindset, the way that you would question the financials, it's no different. And you just have to bring that mindset to clinical governance. It's also understanding clinical quality, making the time both for your own education, to stay contemporary and understand what you need to understand. I think that's really important. And probably the other two that I'd add is diversity of experience, I think is really important, and looking for boards and governing bodies to ensure that they've got a diversity of voice at the table. People with different backgrounds, different experience, different ways of viewing issues, I think is really, really important and generates the right conversations. And then the last one I'd say is just always every important decision, you need to be asking, what is the impact that this will have on the residents in our facilities or those that we provide care to, and our people, our staff? You just have to ask that for every single important decision.
Fantastic. And I think for those of you that joined us on our Voice of Consumer webinar, which I think from memory was webinar 3, there was a lot of discussion around that and around bringing the voice of the customer in. So I think if people are interested, that's well worthwhile going back and actually engaging with that webinar to actually work through and come up with some different ideas, because there was lots of different things that were brought forward in that webinar. Melanie, can I ask you, what are some of the challenges and areas of focus regarding building a good clinical governance culture in aged care organisations?
Some of the challenges certainly relate to knowledge and capability, and whether that is fit for the current cohort of needs within an organisation or indeed within an individual service. And understanding when those things change, when key personnel change, or when a new resident arrives or something changes and there's some new issue that arises. I think being responsive to those sort of things and being aware and enabling your staff to know that you're actually interested and you want to know these things is really important. But it certainly is a challenge, particularly at times where workforce is changing rapidly. Having said that, a very satisfied, well-supported workforce is less likely to be leaving your organisation, I might suggest. But another challenge, I think, is enabling people to understand not what they have to do, but why it matters, because people are much more likely to change their behaviour if they understand why it matters. And that goes up to the very highest level. So many board members and many people in the management team who don't have a clinical background may not understand why these clinical things are not just an isolated minor thing. They actually matter. They matter in very, very broad and very, very important ways. And it's actually quite simple to communicate basic information about why things matter if you've got a good clinical person who can understand impact and flow on. So I think that's part of the challenge. Another part of the challenge is in a very diverse group of consumers that clinical care means very different things to each of those people, and you can be pleasing or satisfied with the care for the majority, but you also need to focus on individuals. So how you as senior organisation people know who is overseeing these things. It's clear lines of oversight and information coming to you. I think that understanding that knowledge input, if you like, intelligence about what's actually happening in the organisation it's so crucial to governance as a whole, and that it's very easy to understand output, but it's not quite so easy to understand lines of input. And the other thing is that there's a relatively disempowered end user, that there are many people in your service who have got profound cognitive impairment or inability to express themselves or advocate for themselves, and understanding their needs needs a higher level of engagement and thoughtfulness. So it's easy to focus on people who will tell you what they want and need, but you need to focus on everyone as a matter of ethics, I guess, and conscience and genuine satisfaction in your own work, that you're doing things the way you would want them to be done for you. So I think those are some of the broad challenges. There's interactions with external people and agencies as well, I think, can sometimes be a challenge when they can have a big impact on your organisation.
Fantastic, thank you. Just changing the question ever so slightly. So Marie and Julie, I'm interested in both of your thoughts about building on the challenges that Melanie's articulated. But what are those challenges then as a collective governing board member? Like, how does that translate through as a board member? And any ideas about how we might be able to overcome some of those? And Marie, I might come to you first and then back to Julie.
Sure. I think as a board, there are certainly things that we can do to help overcome some of those challenges. So some of it is thinking about what the organisational priorities are, that if particular clinical improvements are identified as part of the organisation's strategic plan and reflected in the executive's key performance indicators, that sends a really strong signal about how important the board thinks that those things are. We certainly can make choices about where we allocate resources, whether we'll be putting funding into buildings or into executive salaries or into the pay for our aged care workers. So thinking about strategic priorities and resources. And I also think that governing bodies have a really important role to play in advocating with some of those external agencies. So we know there are significant pay disparities between people who work in aged care versus those who work in acute hospitals. And I think that through our roles as leaders of these organisations, we can certainly advocate for broader policy reform as well.
Fantastic. And Julie, your insights from your experience.
Probably don't have a huge amount to add, other than I think one of the biggest challenges we do face in across the board, probably outside of hospitals where clinical governance is well established and embedded, is really just an understanding at all levels of the organisation what it means. And so it begins and ends with the board. So clarity around your role as a board member and the expectations. And I think the other thing is ensuring that there is, again, back to culture, the ability for staff to speak up. I think the reality is that in many of the sectors that we're talking about here, there have been and are issues with bullying and poor behaviour of staff and residents, let's be honest. So I think being aware of those issues and just ensuring that you're doing all you can to hear the voice of the consumer and the voice of the staff at board and governing body level is key.
Fantastic. Thanks, Julie. Now, I'm actually going to jump to one of the questions from the audience because I actually think it's a really timely question. And I'm sorry, Linda, you've asked the question, but I'm going to take a little bit of a spin on what you've asked. But I'm interested, I think sometimes the perception is that when we're talking about all of this, it's just residential aged care. And so I'm really interested in the perspectives from the board. Is this just around residential aged care? How does this apply to home care or CHSP? And I might, Julie, come back to you as sitting on as a board member of an organisation that delivers all of those services, and then Melanie, interested in your viewpoint in terms of your role within the Commission.
So the short answer is yes. If you're delivering services that deliver clinical care, and I'm just going to say care, and again, this is the language piece, I think, which is such a barrier across our health and community care sectors. And I also work in and around mental health, where there's a lot of peer workers, not clinicians, delivering care. So the question is, if you're delivering care, how do you ensure that that is reliable and at the level that you expect, that if you were in that facility, or if you were receiving that home care, or if you were calling that mental health hotline, the care that is best practice? So for me, it's about translating. And for professionals who work in and around clinical governance, I think a big part of your role is translating what is appropriate for that organisation. And just lifting and shifting a clinical governance framework or metrics from one sector to another is not going to work. So you need to understand what your clinical risks are, or care risks, your risks around care delivery. How do you know what they are? How do you get visibility of them? How do you measure them? Whether that's numbers or narrative or both, hopefully both. And it will look different. So the way that you're ensuring high-level care in a residential facility will be slightly different to community care, slightly different to family and disability services, different to mental health. The fundamental principles and the fundamental frameworks are the same. It's that translation piece that will differ.
Fantastic, Julie. Great answer and great insights. Melanie, any other perspectives that you want to add to that?
No, I completely agree. Well, yes, but I completely agree that it's not just if you're delivering clinical care, and I want to be really clear about that, because if you deliver care, you are in a position of impacting on clinical care if your care is insufficient in some way, or neglectful in some way, or wrong in some way, done wrongly. But you're also in a position to potentially be the only person to detect risk. So if you are showering somebody and you're not delivering clinical care, but you notice that the person is bruised or has a pressure injury that's new or is newly confused, you don't have no responsibility. You clearly have a responsibility to detect that something has changed and that something needs to be done. And it might be something simple or it might be something complex, but you can't say you've got no responsibility because you are only delivering care. And where you are delivering care, particularly care that impacts on the clinical state of the person, or to a person who may have a declining clinical state for other reasons, you need to have very clear processes so that you know that the care you think is being delivered is actually being delivered in the way that you want it to be delivered, and that that you have mechanisms that are very robust to know that you are certain what's going on out there where the care and services are being delivered. So it's really, you can go back to some cases from disability that were in the media where there are risks involved in care where there's, little oversight potentially, where it's a single carer, where it's a cognitively impaired care recipient, where you are relying on somebody saying they did something, but nobody's actually looking at outcomes and looking at whether or not that's the case, that those things are actually happening. So it is a slightly different process, but the risks are clear, and the potential to be excellent is really there. And the way you communicate and oversee that, and the way you communicate your expectation that everyone is going to contribute to those issues in your particular organisation, I think it's really important.
Fantastic. Thank you. Marie, I'm going to ask a question of you next. Can you share your perspectives on the importance of setting up that culture of continuous improvement? I think you touched upon it in your introduction, and I'm just interested to find out a little bit more around that.
So I've recently joined one of the governing bodies of Te Whatu Ora, which is the new Health New Zealand board. And one of the things we say at every board meeting is that every single person in this organisation has two jobs: to help deliver care and to help improve care. And that whether you're a housekeeper or a care worker or a senior doctor or a board member, your jobs are to help deliver care and to help improve the quality of care. And I really love this ethos, that that's a thread that should weave through the whole organisation. And for me, a huge part of that culture of improvement is allowing the voices of some of those frontline care workers to be heard, because often it will be some of our lowest paid staff who have the most valuable insights into what would really make a difference in the lives of our most vulnerable residents. So having those mechanisms where their thoughts and ideas and recommendations about how things could change and improve, and to actually support them to see the results of that feedback. I think you can have all of the surveys in the world asking for recommendations, but what really makes a difference is when managers are coming back to people quickly and saying, thank you for that fantastic suggestion, this is what we're going to do about it.
Fantastic. So Julie and Melanie, any other thoughts from you in terms of how you actually set up that culture of continuous improvement?
I think it's important to clearly identify how you're going to know what needs improving. And what the situation actually is. So I think you need to look at what you know and how you know it, which is the first step, and then it's of course what you're going to do with that. But there's numerous ways in which you can understand what's going on. Possibly the most powerful is to get out on the ground and actually have a look at how your people are being served food, or how they're being spoken to, how staff are interacting with each other. How the place smells and looks, and how visitors are being welcomed or otherwise, etc. But beyond that, you've got a number of ways in which, and some of them would be your own creative ways to look at what's going on. So you can clearly look at your quality indicator data, you can look at your SIRS reporting data, your serious incident, you can look at your own incident management systems, you can look at audits. You can ask for audits or think specific things to be looked at. You can look at your consumer engagement and feedback, and then see what things you think you can focus on to improve. So I think it's looking at where you're getting your information from as a first, and if it's insufficient, that data's not just data. Data is information for you to do something with. If it's insufficient, put in processes to improve that. And if you think it's there but you're not seeing it, then that's something you can address.
Fantastic. Julie?
Yeah, I think there's a couple of things in there that can assist to build on setting up a culture of continuous improvement. And another one I'd add is being really clear on what you reward. What sort of behaviours do you reward in your organisation? Are you rewarding a compliance mindset? Blindly following policies and procedures without allowing what I call that good variation. We know that there's this thing called unwarranted variation in care, which is care that's not of value to the person receiving the care. But then there's good variation. So how do you set the guardrails as a board around behaviour that you expect, but then allow at the point of care that good variation in care, that care that is delivered in a way that is right for that particular individual? And that's where real continuous improvement and innovation occurs. Those changes that happen often at the point of care. So allowing that to happen in a safe way. And then how do you hear that? And again, it's usually a combination of metrics, but often it's stories and hearing good work that's happening at the front line, and getting out and seeing it yourself and chatting to people is invaluable for sure.
Fantastic.
I think one of the other things is questioning yourself as a board, because when things go wrong, when something goes wrong, and the response, for example, is to identify a staff member that is deemed to have been responsible for that and dismissing them, really the response should be quite different to that in terms of how did we as an organisation allow this to happen? Was it an education? Was it a role delineation? Was it an oversight? Should we have known about this in advance? Were there warning signs? And how should we have done things differently, which will guide how we're going to do things differently in the future. And I think that if staff see that they're continually the thing that's caused things to go wrong, that will foster cover-up rather than open disclosure, which leads to problem solving.
Fantastic, thank you. I'm going to start with Julie for this question, and I'm going to just bring in a little bit of one of the questions that the audience has asked as well. So I'll start with Julie, and then I think probably go to Marie or Melanie. So two parts to this question. So number one is, what will be the impact of the incoming strengthened clinical governance requirements for your governing body? But the second bit is really around the clinical representation. And apologies, because I am just trying to get the right question to actually be able to nuance my answer. And there's so many questions coming through, I have now lost the question. So just bear with me. So Julie, do you want to start asking that question? And then when you finish that, I'll ask you, but it's about clinical representation on the board. So if you can start about the impact of the strengthened clinical governance, and I will just get the right question.
Sure. So as all of you hopefully would be well aware, there is the requirement now to have a quality care and advisory body that includes people on that committee and that body and your board with appropriate skills, including clinical skills. The great challenge, of course, is finding all these clinicians. And the organisations that are in a good place were proactive and started this some time ago, because the writing was on the wall that this was coming in. It shouldn't have been a surprise. So it is going to be hard to find clinicians who are interested in this work and have the appropriate skills. My advice is to think laterally. Think of clinicians who may be outside of the sector. They bring skills and knowledge from a different lens than from within the sector. And it can be a really valuable way to get, again, that diversity of thought. So think around clinicians that have worked in different sectors. Think around clinicians that may not be from traditional nursing or medical backgrounds. Allied health clinicians have brilliant insights into care. So I think that's a couple of tips around finding those clinicians. I mean, one of the big challenges is going to be payment. For smaller organisations, these are volunteer positions, and it is a lot of work. And it's a lot of work in smaller organisations where you don't have the executive and, large support that the organisations that I work with, Uniting Care Queensland and Uniting New South Wales, have large clinical governance and quality teams. So it is going to be really difficult for smaller organisations. And I don't have an answer here for you, but I think just think laterally around where you can find people that are interested in quality and safety.
Yep. And so Julie, just noting that obviously we have talked about this previously, but I think that includes going broader than potentially medical practitioners, nursing, but also potentially looking at some of the many allied health practitioners that have got an interest and have got a good understanding around quality and safety as well.
Yeah, and thinking about organisations that you can go to help you. I'll put in a bit of a plug for Women on Boards here. You can list positions on Women on Boards, and there are a lot of clinicians out there who would like entry-level roles onto committees and would be willing to do it for a small fee or pro bono. So think about how you can find clinicians outside of the aged care sector. I think they've not been tapped into in any great way in my experience.
Fantastic. Thanks for those tips. Marie, I might go to you. So noting that we have to, as an approved provider for home care, you do also need to have a clinician on the board. But I think for services that aren't an approved provider, how important is it to actually have, where it's not a requirement to have a clinician, how important is it to have a clinician on your board?
So I'm probably quite biased in my response to this, but I think that having a mix of clinical and non-clinical skills is absolutely crucial. Sometimes when things have gone badly wrong in health sector organisations, it's because the board has been steamrolled by very confident clinicians within the organisation who shut down lines of inquiry and dismiss the board's concerns. And I think that having somebody with the clinical experience and confidence to ask those questions and to not be intimidated when clinicians try and say that this is none of the board's business. So I think it's crucial to have that skills and experience, but also to have the non-clinical perspectives. And I was smiling at those earlier comments about the difficulty in finding people to serve in these roles, because I have completely the opposite experience, where every fortnight or every week I get phone calls from clinicians who are saying, I've got some governance experience and I'd really love to expand my board portfolio, and where on earth do I find roles? So I think that there are lots of very skilled and capable clinicians in Australia with some governance training and some degree of experience who would love these opportunities. So I don't know that it's an absolute shortage of people. It might just be a need for some better matchmaking between organisations and clinicians with the appropriate skills and interest in learning, because everybody does need to start somewhere. And I think that if you have a clinician who's demonstrated some leadership skills and a capacity to think about things from a big picture perspective and with an interest in quality improvement, they could certainly learn the skills they needed to make a valuable contribution quite quickly.
Fantastic. And just picking up on that, and this is another one of the questions, you talked about that imbalance and having a large number of non-health professionals. And I think this is more around the delivering care. And so, Melanie, I'll also come to you after Marie's perspective. How do we, any suggestions about how do you balance that in terms of having clinicians and non-clinicians at a board level, but also at a senior exec level? How do you balance that so we can deliver safe quality care?
Well, even among the frontline staff, it's an extraordinary challenge that in aged care, often you're providing care to people with complex health conditions with multiple comorbidities, and your frontline staff are having to make very complex judgments and assessments without necessarily having clinical skills or experience. And so I think it's so important to have that trust between the clinicians and the non-clinicians in the organisation, to have an environment where it's safe to speak up, where it's safe to ask those questions, where it's okay to say that you're not sure, or to even just say that you've got an uncomfortable feeling about something, and to be able to receive input from other members within the organisation who may have a greater depth of clinical experience, whether that's as a frontline carer, as a village manager, as a manager of a home care service, or on the board.
Fantastic. And Melanie, once again, a slightly different take on that question. We've got a question from the audience that is she's the team leader for clinical care, and feel that lack of understanding from non-clinical colleagues means that they don't identify the seriousness of reporting. So any suggestions about how to overcome that so the team leader can actually do what their job is and actually be accountable?
Yes, I think it's de-siloing clinical care from all the other components of what's happening in an organisation, and at a board level, not just saying, well, clinical issues will leave to the clinical board member, but using that clinical board member to explain to the rest of the board why, at a high level, if you like, or as much detail as is necessary, why things are important, what the broader impacts are, what the unintended consequences of decisions that they might make might be. So actually using them to help everyone understand rather than just leaving certain things to them. And at a non-board level where you've got non-clinical staff, that to me would go, I think that's what the person's asking, would go to really clear permitting people to come, a safe place as described, to come with any concerns, that they will be taken seriously and that they will be escalated appropriately, and that the clinical team will have appropriate levels of escalation, and that they will be empowered to bring in external advice or external people, that it isn't just one person expecting to solve all the clinical problems in an organisation. The links have to be there, and the development of understanding of impacts and risks, and that all alarms, alerts, concerns, questions will be taken seriously and acted upon. I think that embeds those processes as something that someone will continue to do.
Fantastic. Thank you. I'm going to keep going through the audience questions just for a little bit, because there's some great questions and I want to try and make sure we cover as many as possible. Julie, probably this one is probably for you. If you do not have a board of management, it's because you're part of a local government, what suggestions do you have for staff involved in terms of clinical governance oversight?
Look, I think at the end of the day, the structure that you are required to work within from a governing perspective, you just need to ensure there is clarity of roles and accountability. One of the greatest enemies of quality and safety is confusion and complexity. So regardless of the structure that you work within, my advice would be to ensure that there is clarity around who is accountable for what. And in that environment of, shared or brokered care, which is probably not quite what this question is asking, but it's another area of the area where we deliver care. That's another area where you can see a breakdown in the quality of care because simply there is lack of clarity around accountability and responsibility. So that would be my advice. Just make sure you've got that clear.
Fantastic. Thank you. Marie, this one's for you. Really interested in your perspectives around if quality performance indicators are largely self-reported by the workforce, so things like falls, etc. How can board members be confident that there is rigour in the collection of the data? And how much can you, as a board member, can you rely on those indicators?
That's a great question, and it comes back to this culture of trust where people feel safe to make those reports. I always think of quality and safety as a courtyard in the middle of a house, and that you need lots of windows onto that courtyard. And so self-reports from staff will be one window into the courtyard, but you want to also be peeping through other windows, which means hearing directly from residents and families, whether that's through complaints or whether that's through feedback. You're really interested in information that might be coming from other sources. So sometimes there'll be benchmarking data that's available if there are particular types of claims being made. Sometimes hospitals can provide you information. So, for example, if you hear from a hospital that they've received an admission from somebody with a fractured neck of femur and yet that fall wasn't reported by your staff, you might be curious about why that is. So I think this idea of quality and safety is being in this courtyard, and the more windows you can have into the courtyard, the better your perspective on what's actually going on in there.
Fantastic.
One other thing that we found really helpful is benchmarking with other organisations. And sometimes if the data that we're receiving is really way out of line with peer organisations, we need to ask some questions about whether that's about a difference in measuring or a difference in reporting, or whether our care really is better. And if it is better, what can we share with other organisations about how we achieve that?
Fantastic. I've also got a follow-up question from one of your introductory responses, Marie, so I'll stick with you for the time being. One of the audience members picked up when you were talking about that balance of caring culture but also compliance culture. And just interested, their comment is that they know that they're not mutually exclusive, but they are often viewed that way. So just interested in your perspective around that.
Yeah, they certainly can be seen to be in tension, and I loved the comment earlier about good variation and unintended variation, that I think that there is a baseline of compliance that supports good care. So, for example, making sure that a shared goals of care document, or whatever the equivalent in your organisation, has been completed for every person who you're providing care to, so that you understand their values and their hopes and their dreams and what's important in their life. And if we can make sure that every single person in our care has had one of those shared goals of care documents, that's a form of compliance, but it also really supports compassionate care. And at the same time, you do want to allow enough flexibility for these really beautiful moments of resident or person-centred care to occur. And sometimes when I'm going around visiting villages, I'll ask the staff, what rules have you broken in the last week to provide great care? And they're often really gorgeous, quirky things like, I'll let this resident eat his ice cream before he eats his dinner, if you've got someone with a really poor appetite. But asking that question about what rules do you need to break to provide great care can give you wonderful insights into where compliance and care might be in tension with one another.
Fantastic. I love that concept.
Can I add to that just very briefly?
Absolutely.
That I am very firmly of the view that good care and good processes around care will nearly always be compliant, that they're not mutually exclusive, that good care supports good compliance, and that you would be starting with good care and good processes, which is kind of governance and care delivery, and then seeing where you're not you might not be compliant, and either fitting those in or working out that they actually do relate to care as well.
Fantastic. I have got, I think, one last question from the audience, which I think is an excellent question for us to end on. So I think we will come to each of you as panellists to get your perspectives. It's a double-barreled question. How important is it for the board directors to be seen within the organisation by the staff in regards to improving the clinical governance culture? And then the second part is, how do you strengthen the partnership between board and management in setting up the expectations in delivering good clinical governance? And I think we'll go Julie first, then Melanie, and then Marie.
Look, it's absolutely critical that you lead as non-executive directors or governing body members the importance of improving clinical governance culture. And I think we've spoken a lot today about how you might do that. So, it begins and ends how we provide great care. So it's just so important. How do you strengthen that partnership? I think it comes down to, again, I call it the infinite journey of quality and safety. You're never there, right? So it is a partnership with the executive and management where they are bringing information to you. You're continually questioning what you're seeing, in a insightful, pleasant way. But I think always being alert to the challenge of hubris and, somewhat drinking your own Kool-Aid at times about the quality of the care you're providing. Being wary of all green is one of my favourites. So, are things as good as the information is telling you? And at the end of the day, it's building up trust with the executive and the clinical governance and quality team so that you can hear the stuff that's going wrong, and you are hearing about it in a timely manner.
Fantastic. Thank you, Julie. Melanie, your thoughts on this?
I think it's very easy, particularly in a big organisation, for the board to be a concept and be seen as being quite disconnected from the organisation. And I think part of embedding the board culture in the organisation is humanising the board, as in the board are humans who absolutely care about what's happening. They're not just someone that's going to tick the boxes and pay lip service, that they are keen to know that the care they are being told is being delivered, that the changes they intend to make are being made, that they are understanding the challenges and the difficulties and the successes, that they are seen as keen to know, keen for things to go well, and that they're motivated to find these things out. So it's being seen to be communicating and to be seen to be engaged, because you know in your heart that you care, but does your organisation know in their hearts that you care?
Fantastic. Thank you, Melanie. And Marie, your last words around those two very important questions.
Thank you. They're great questions. All of the audience questions have been wonderful today. It's been such a thoughtful discussion. So I've been serving on boards for nearly 20 years now. And I think at the beginning, I was a little bit sceptical about how much change the board could actually achieve. But over that time, I've seen the chairs of boards change. I've seen the membership of boards change, and I've seen the way that those values flow down through the organisation. And I am now absolutely convinced that strong board leadership makes a difference, all the way down to the care that's being provided at the bedside, and that our values and our thoughts and our words all have ripple effects, much greater than we might necessarily appreciate at the time. So yes, it's incredibly important. In terms of the board and executive working together, one analogy that I really love is this idea of a pressure cooker in the kitchen, and that you put all of these ingredients in, and you kind of, as a board, you want to turn the heat or turn the pressure up enough that these ingredients turn into something magic. You know, you want things to change. You don't want to be left with a pile of raw onions at the end of this process. And so you need to be applying some pressure to achieve that change. But as a governing board, if you turn the pressure up too high, you're going to end up with soup exploded all over your kitchen. And that's not in anyone's interest. And so it's this really fine judgment of really listening to your executive leaders and understanding when the time is right to challenge them and to set those expectations a little bit higher, and when the time is right to allow things to simmer along with support from the board, but without necessarily trying to implement a major change. And I think there's a real skill in that, in really being attuned to the organisation and knowing when the right time is to push for that next level of improvement.
What an amazing analogy to finish on. I think, Marie, that was absolutely perfect. Can I just say a very big thank you to all three of you? That has been an amazing discussion, really great insights, and also to the audience, fantastic questions. For me personally, some of the many, many takeaways and things that I've written down is about making clinical governance engaging, having that level of curiosity, making sure there's airtime for when things go right as well as wrong, and that culture, and the fact that there'll be micro-cultures within your culture. And Marie, certainly I love the what rules have you broken today? I think that was fantastic. But that was just a very small number of a very large number of things that I've written down as we've been going through today. So to the audience, thank you so much for joining us today, and thank you so much for your absolutely fantastic and insightful questions that has helped us to be able to work through the webinar today. Directly following today's event, we'll be sending you an email with a link to provide feedback. Please take the time to do this, as it's really valuable for us to hear from you. We're trying to adjust the experiences as we progress through the program, and the feedback is very critical for us to be able to do that. Please also ensure you complete the diagnostic tool, which will provide some insights and help direct some of your learning. As mentioned earlier, please some of the related learning activities shared in the reminder email that may help you in terms of the topic today include the Clinical Governance online learning module, the Continuous Improvement online learning module, and the Continuous Improvement and Succession Planning Toolkit. Lastly, but certainly not least, please make sure you join us for our next webinar on the 1st of March, which will focus on digital adoption, building a connected sector. Thank you very much for joining us today.